And I just started the recording again so that others can watch this presentation if they can't make it live today. Thanks everyone for joining us. I think this is the third seminar in our Department of Epidemiology and Biostatistics Digital Health Initiatives seminar series, excuse me. And we have been really focused in the seminar series. It's open to the general community, it's focused on UCSF, but I would say broader than UCSF, on more applied topics in digital health that really address common research barriers, major methodological considerations, and the emphasis of translation into practice of digital health research to really increase the impact and the science of what we're doing. So today's session is really wonderful. It's really focused a lot more on the computational side and the intersections between computational and data science and digital health. And our wonderful assistant professor in epibiostat and also member of the Baker Computational Health Sciences Institute, Dr. Jean Feng, is going to lead today's seminar and moderate a discussion at the end. So I'm going to hand it over to her.
Thanks, Courtney. Yeah, thanks everyone for coming. So today we have three panelists. We have Thu Nguyen, Dr. John Kornak, and Dr. Geoff Tison. I think we have everyone here now. Yeah, sweet. Yeah, and as Courtney mentioned, we're kind of focusing on the computational methods for today's seminar. And obviously computational methods for digital health studies, though we're defining digital health here pretty broadly. So we have our speakers are going to talk about imaging data, social media data, telemetry data, and so on. So we'll start off with Dr. Thu Nguyen, who was at UCSF just until late last year. She's made the move to University of Maryland to become an associate professor in the Department of Epi and Biostatistics there. And she's a social epidemiologist, and her research analyzes various data sources using both quantitative and qualitative methods to really understand the impact of modifiable social factors on minority health and health disparities. And then after that, we'll have Dr. John Kornak, who is a professor in the Department of Epidemiology and Biostatistics at UCSF. And his research has been primarily on analyzing imaging data, a lot of work in brain imaging as well. And I guess he'll be talking about this today, but he takes kind of a Bayesian angle oftentimes. And as a side note, he's also been spearheading a lot of the data science education programs at UCSF. So that's probably also relevant here. And then last but not least, we'll have Dr. Geoff Tison, who is a cardiologist and assistant professor in the Division of Cardiology here. And he applies machine learning and deep learning techniques to large-scale electronic health data from heterogeneous sources to really understand personalized cardiovascular prognosis and disease prevention. And so each speaker will kind of talk for about 8 to 10 minutes, and then we'll have a Q&A session for the rest of the hour. So you're welcome to put in any questions you have in the chat box. I think that's kind of our primary mechanism here. And we also have a few questions of our own. So with that, I guess, Thu, do you want to take it away?
Thank you so much. Thank you for the invitation, and I'm going to share my screen. Hi everybody, so today I'll be talking about using Twitter data to examine error level, racial attitudes, and racial bias and health beliefs. So first, one of the first questions I get asked is like, why do you use Twitter data? So I use Twitter data and think of them as a collection and to tell us important information about social and cultural norms and beliefs. And every day we see expressions and information sharing on social media and other online sites on a range of topics, including sensitive topics such as medical mistrust, beliefs about vaccine, and expressions of racial prejudice. And all this in real time. So we can use social media to capture temporal and geographic patterns and how these social and cultural norms are changing over time that have implications for health and health disparities. I think of the data collection and the measurement as capturing an important aspect of cultural racism. And David Williams defines cultural racism as the infusion of ideology of impurity in the values, language, and imagery and unsafe assumptions of a large society. So we can see this expressed in movies and literature and art, and of course on social media. And cultural racism is important because it forms the foundation, the context from which discrimination can thrive, both at the individual and institutional level. So these studies are seeking to kind of capture and measure the social context. So during the pandemic, many important things happened that are related to race and racism. So when I was doing my K99 R00 and R01 that just started, I was like, I cannot ignore these events that are related. So some of these examples are that occurred during the pandemic, and how my research kind of used social media to examine some of these. So during the beginning of the pandemic, we saw a rise in anti-Asian sentiment. This occurred during the beginning, and it was like blaming Asians for the pandemic. So using Twitter data, I collected tweets from November 2019 to June 2020 to kind of see if we can systematically look at some of the patterns. I collected race-related tweets broadly, but these analyses here are specific to tweets referencing Asians. So we see that for several months, there was like a pretty stable pattern of sentiment. So these are analyzing the sentiment of tweets referencing Asians, but then in mid-March, we see a peak that lasted for a few weeks, and then a decline after a few weeks, but not to the same level it was before. And the peak corresponds to when former President Trump and other political leaders began using terms such as Wuhan virus or China virus or other stigmatizing terms. So here we see in tabular form, kind of like the spike in negative sentiment tweets referencing Asians. And then I looked at tweets referencing Chinese in particular, and saw a very similar pattern to Asian tweets referencing Asians in general, kind of indicating there's a spillover effect where Asian subgroups can be conflated with one another, or confused, or follow the same pattern as Chinese specific tweets. So here are some examples of tweets expressing kind of racism or blame. There is a trigger warning because these include offensive tweets. And then there's also tweets that express condemnation for these the prior expressions of racism. So during the pandemic, we also saw the tragic killings of Ahmaud Arbery, Breonna Taylor, and George Floyd. And this ignited a national conversation about police brutality and general racism in the US. And so I wanted to study how these killings impacted discussions about race and racism on Twitter. I collected tweets from 2019 to 2020, November to September, and performed a sentiment analysis on a random sample, 1% random sample of tweets. So these are tweets specific to referencing Black people. So we see across the 4 US regions after the killing of George Floyd, we saw a decline in proportion of tweets referencing Black people that were negative. This lasted for a few weeks and then began to climb back up. So similar to the pattern that we saw previously with the Asian tweets, here we see it for Black tweets after the George Floyd murder. And the pattern was very similar across all 4 US regions. So we wanted to look at qualitatively what were the discussions that were occurring before and after the killings. So before the killings, we saw expressions of cultural pride and empowerment and affirmation. And after the killings, we saw these as well, but there was an increase in self-reflection tweets, or tweets acknowledging structural racism or one's privilege that was not acknowledged or reflected upon before, and more recognition of history of racism in the United States. There are also more action-oriented tweets, so actions, calling for actions against police brutality, engaging in protests, signing petitions, voting, and being solidary with the Black community for the fight for social justice. During the pandemic, we also saw, of course, the development and the role of the COVID-19 vaccines. And there's important intersections between race and racism and vaccine rollout. So this is a fully qualitative paper looking at a random sample of 1,110 tweets, kind of looking at how people are talking about race and racism and COVID-19 vaccines. So for the content analysis, we developed a code book by reviewing about 335 tweets to find the code book, and then we use this coding scheme to double code all the tweets. And then 8 members of the team were all together and to discuss any discrepancies and come to consensus on the final code. We then conducted the thematic analysis within each code. So the themes that we saw were vaccine support. So these included vaccine affirmations, so people who are excited, enthusiastic to get the vaccine. And then there are also tweets stating support, but also doing it in a negative manner, like through insults or negative language. There were tweets about development of the vaccine efficacy in terms of support. There's also some racist vaccine humor where people express, you don't need to worry about what's in the vaccine if you eat certain types of food. So these are some selected quotes for the vaccine support theme. I'm a Black woman, I'm immunocompromised. As soon as I can, I'm getting the vaccine. It doesn't have any COVID in the actual vaccine, as an example. And then there was also vaccine oppositions. And so these included direct opposition where people say they will never get the vaccine or like directly. And then another set of tweets expressed that they had some concerns, but they were more open to getting vaccine at some point. And people also talked about concerns about adverse reactions. So here's some selected tweets. And one sub-theme that was particularly interesting to our research team was the vaccine hesitancy tweet. For example, this tweet, the initiative to publicly vaccinate Black and brown people against COVID in an effort to encourage other Black and brown people to get vaccinated is cute and all, but why are they going first? There aren't white doctors and nurses readily available. So I think this was an interesting theme because it touched upon kind of like the history of racism in healthcare system. And so then there was like, on the one hand, the call to encourage and provide access to people of color, but on the other hand, being met with skepticism because of the underlying past and current racism that exists within the healthcare setting. So that was interesting. And then there was themes of vaccine conspiracy and misinformation. So these include tweets that were counter to the science and also counter misinformation about government's role, like implanting microchips or using the vaccine for population control. There were various conspiracy theories, including a race extermination conspiracy theory, and also misinformation about immunity and protective factors, not needing vaccine if you have a healthy immune system. So some example tweets here. So talking about changing DNA or causing infertility or eliminating populations. And then the last one, if you eat healthy or take vitamins, then you don't have to worry about getting the vaccine. There were discussions about equity and access within the tweets, discussions about racism occurring and pointing out health disparities, and also some tweets talking about the importance of ensuring vaccine access for some communities. So here are some example tweets. Tuskegee and COVID vaccine. The massive crime of Tuskegee is knowing there was syphilis treatment and not offering it. It would be similarly be a massive crime to have the vaccine that works and not offer it. Medical racism is real. Helping you get the vaccine, is it? So kind of like the complex issue of racism, but also the importance of having the vaccine be accessible to people of color. And then discussions about undocumented workers and having the need to get certain populations facilitating access. So there were discussions about representation. People took pride in Dr. Kubert helping developing the vaccine. And also there were people who were happy to see certain role models like community leaders, civil rights leaders, and celebrities talking about the vaccine. Here are some quotes about it. So these examples kind of demonstrate the use of social media to collect information on beliefs and attitudes and to capture the social context related to important topics. So new approaches to measuring and capturing the social environment might increase our understanding of the social context and how it can influence health and health disparities. I'd like to thank my research collaborative, Big Data for Health Equity, and my funding, and my contact is below. Thanks.
So, I guess next I'll have John.
Okay, thank you. Let me figure out to share my screen. Okay. So thank you for the invitation and the chance to speak here. I guess my talk is one of those that is has the loosest connection with digital health exactly, but images are digital things. They're
We're
recorded.
defining it broadly. We're good.
Yeah, so I feel okay. It's all right. So I'm going to talk about Bayesian image analysis in Fourier space, and I'm going to try and do it in 8 to 10 minutes, which means I'm going to skip a lot of details along the way. I'll start by just like the briefest of descriptions of conventional Bayesian image analysis. I'll then mention the other component we have, which is Fourier space, and then how they're combined into Bayesian image analysis in Fourier space. I'll talk a little bit about an extension working in a data-driven kind of empirical approach to building priors for BIFs. And then lastly, I'll just point to where we're going next, which is with wavelets. Okay, so this is the conventional Bayesian image analysis framework. You have some kind of imaging, and what you observe is this data Y, which is the truth plus noise. But what you really want is to get at the truth, or the underlying thing that you're measuring. But in practice, you don't get to see that. I'm showing it here. So really, this is what you get, and what you want to try and do is reconstruct that. Or maybe not exactly this. Maybe what you want is an enhanced version where if you're looking for breast cancer tumors, you would want those enhanced relative to the background some way. And the Bayesian image analysis formulation is a good approach to being able to do this. There are two main parts in a Bayesian formulation. I'm not sure how much of the audience is aware of this, but you basically have a likelihood component, which is your probability distribution. This pi represents a generic probability distribution. It describes the process that takes you from the truth to what you actually get to observe Y. So this is, you have the truth, and then there's some noise added in there, and this is what you get to observe as the data. Then we have a prior that we're describing the known characteristics about X. This is where we're telling the machine that these are the kind of reconstructions we like for whatever reason. There's some, whether it's we want things that are smooth or whether we can detect edges in there, all of this goes into the prior. And then we use Bayes' theorem to get a posterior estimate just by multiplying the prior by the likelihood and extracting the most probable reconstruction from there. When we develop priors in image space in the conventional framework, we have the pixel, or the voxel, as the unit of data. So each of these squares is one pixel in these images up here. And you try to model the dependence between neighbors somehow in the image, or model the structure of shapes that you might be observing within the image. So you get a lot of dependence between your individual observations. That's kind of a difficulty of working with conventional Bayesian image analysis. It causes difficulties with computation. So, but when we're looking in Fourier space, which is where we're going to work in, now we can start to think about things in a more independent kind of way. So this is a little snapshot of the moon, and I've split it into different parts of Fourier space. Right in the center here, we have 0, 0. So this is 0 in terms of spatial frequency. There's no variation in the image. It's your overall mean. Then in the next image across, we've got some central frequencies. So these are, you think of them like, the sea. It's like there's waves in there. These are the slow changing waves. And as you look at what that part of the image is here, you see it's this blurry, smoothly changing thing. Then as we move into higher spatial frequencies, we get sort of mid-level objects that get accentuated. And then when we come out into high frequencies, we're in the noise. Where, yeah, in the noise or very small objects in the image. And so the main idea is that for each location in Fourier space, we have a spatially correlated process. So instead of having this dependence when we're working in image space, let's just think about a bunch of independent processes over Fourier space. Okay. And this is kind of the big picture of what we do. You have some observed data here. This is simulated data, not real of a brain. We want to work in Fourier space, so we take a fast Fourier transform. We think about a noise process in image space, and then we have to think about what that process is in Fourier space. We need a prior. So let's say a priori, I expect my image to be smooth. Well, that means I want to have higher values in the center of Fourier space where there's low frequencies, low spatial frequencies. I throw all this into the mix in Bayes' theorem, with the key being that I apply it separately at each point in Fourier space, and then extract my estimate, which is still in Fourier space because I was working in there, inverse fast Fourier transform, and I get my posterior reconstruction, which you can see is kind of a smooth sort of, the noise has been gotten rid of from the observed data. You might argue it's a little bit smoother than you would want, and so you would think about a different prior that gives you a better reconstruction. Okay. Working in Fourier space, so this is another example. This is a stock image used in image analysis of a mandrill. And this is another prior in Fourier space that decays from the center, so it has more mass at the center. And these are different parameters for different levels of decay. And you see as we increase this parameter, so this is the truth plus noise, and then D is the parameter that controls the level of smoothness. And as we increase D, you see that you start to get a kind of a smoother image with less noise, but at the expense that as you get too high with D, you start to lose some of the features that you're really interested in. Okay, so this is kind of thing you can do with Markov random fields too, but where we, well, at considerable extra computational expense, but where this area is that I'm going to show you now is what you can't really do with Markov random fields. So now I'm saying I want to select certain frequencies in the image because that's what's going to be of interest. Like I said right at the beginning with the breast cancer example, maybe I want to enhance tumors and I know they occur in a certain frequency range. Well, I can set up a prior that just extracts the signal that I have, removing noise too, in different frequency bands. And you see here low, medium, high. Now, it's not done a great job. It's a pretty crude prior. I mean, it's done a great job at doing what I told it to, which is extract those frequencies. But it's quite simplistic in how it does it. But we can combine priors. So this is combining one of the previous denoising smoothing priors with frequency selection. And now what we get is, you can see, you get smoother reconstruction, but we're retaining some of the features across frequency. And as I move this from left to right, the part that you're enhancing goes from the particularly low frequencies to the higher frequencies. So it's a really flexible family where you can combine different aspects of prior information that you want to incorporate. So very briefly, got some properties that we have when working in Fourier space that take you beyond what you can do with conventional models. The big one is speed. By being able to model as independent, we don't need iterative processes, and it's really easy to parallelize. So if you're working with really big databases, that's a big deal. It's flexible, so if I want to try different models, I don't have to write a whole new set of code like I do with Markov random fields. We get a couple of nice mathematical properties that I'll skip here, but the main thing is definitely the speed and the ability to model different aspects. Okay. I don't know, how am I doing for time? Have I already talked too long, Jean? Or
Yeah, I think you should just quickly
okay,
wrap
so we'll
up.
go. We can extend. We can use a data-driven approach from a big database, and next we're moving on to wavelets, which are instead of working in terms of Fourier space, working wavelet space, which opens up a whole new ball game of different kinds of models we can explore. So, and this just shows we can do a pretty good job already with our preliminary stuff. And we have software available if you actually ever want to try and play with this. And I'll stop. Thanks. Sorry if I went over.
No, we're good. Thanks,
Okay.
John. Okay, next we'll have Geoff.
All right, thanks everybody. Let me just get my presentation going. All right, can everyone see my screen? Can you hear me okay?
It's black for me. Oh, we're good. Yeah, we can see it now.
Great. All right. Hello, everyone. Thanks for having me. I'm Geoff Tison. I'm a cardiologist in the Division of Cardiology in the Baker Institute. And I'll talk today about some of, I've distilled my talk around two or three main themes to try to address this digital health and computational methods that hopefully will resonate with you. Here are some disclosures. So I think this audience certainly needs no introduction that there's very many kinds of data in medicine. One way to categorize it or organize it might be that there is sort of traditional medical or clinical data that doctors and clinicians tend to use, for example, available in the EHR and imaging modalities, other diagnostic modalities as well. And then more recently, perhaps there's another bucket of data that include remote sensor devices, wearable devices, even your smartphone, of course, which can capture a lot of information that in many ways is complementary to the traditional medical data. And so clearly there are many different sources of information that can be captured, but there's much more limited time. And so one of the questions ultimately is, in order to use this data, how can we distill it in a way that can be clinically useful? And so one of the focuses and visions of my group is that with the right types of analyses, we might be able to make the greatest sense of these various different kinds of data in order that clinicians can ultimately better identify disease, categorize it, and ideally prevent it from happening. And in some cases, machine learning and AI tools allows that to happen in ways that other tools might not. And so my first theme, two themes, I guess, that I'll talk about are the following. So, and this applies, of course, broadly to all kinds of research, but the first is to really clearly define your goal. And what I mean by that is, of course, there's a number of goals anyone can enumerate, but in this case, really honing down on sort of the primary one or two goals that take priority for a given analysis can really then help you on the next theme, which is picking the right tool for the right job. And in this case of data analysis, using the right model or the right computational method for the task, because as all of you know, there are trade-offs. So to illustrate this a little bit, I'll talk a little bit about this work, which was published 2 years ago now. And here, our overarching goal was to develop an ECG analysis platform, so an algorithmic platform that could take raw ECG inputs. For example, on a 12-lead ECG, that would constitute a 5,000 by 12 size matrix of values that, when plotted, will give you a standard 12-lead ECG. But that's what the raw data looks like. So we wanted to create a platform that could analyze this type of data to do two main things. The first was, of course, high-performing disease diagnosis or prediction of different tasks. And secondly, identifying human interpretable ECG predictors as to how the model achieved its disease diagnosis. Now, currently with present methods, folks, in order to analyze this, there are many ways, but one of the ways from machine learning AI approach might be to try to do train an end-to-end neural network to achieve disease diagnosis. This can be done, and in fact, we did do this in a separate type of work. But for our stated goals, and particularly the second goal of identifying human interpretable predictors, it perhaps is less ideal. And so for this work that I'll focus on, what we opted to do was develop a two-part model pipeline. So the first part performs ECG segmentation. And for those clinicians in the audience, you'll recall that different waveforms and intervals on the ECG reflect different physiologic occurrences and phenomenon. So depolarization of the atrium, depolarization of the ventricle, the time it takes to depolarize from one chamber to the next, for example. This is all information that humans understand is contained in the ECG, and these are things that we use as doctors, as providers, to interpret the ECG. And so by segmenting the ECG, we could enforce really a constraint on an appropriate model to analyze or make predictions from that raw data using discrete features or combinations of inputs. And so that first model that I'll talk about very briefly first segmented the ECG, and then secondly, we created a classification model to do the disease prediction or regression. And so there are actually many ways to do ECG segmentation, many of which do not involve machine learning or AI, and actually perhaps work even better. We did happen, just for the proof of concept, to build a neural network to do this type of segmentation of the ECG. And then once that segmentation was performed, we essentially sampled across each one of these a priori defined features or intervals, raw samples from the ECG. So what we landed with was a 725 length vector of values that are derived from any given ECG in a way that is interpretable, such that we have 20 samples across the P wave, 20 samples across the QRS, across the PR interval, et cetera. And then for the actual classification regression, we chose a gradient boosted model for various reasons, which I can talk about later if folks are interested. But it allowed essentially for high performance, as well as an increased degree of interpretability through analyzing variable importance factors. And so the second component of the pipeline, as I mentioned, essentially will take that input vector and perform classification or regression depending on the task of interest. So to demonstrate the proof of concept of this platform, we trained the model for 4 different diseases. 3 are shown here, and showed that we could discriminate pulmonary hypertension, hypertrophic cardiomyopathy, amyloid with fairly good performance using the ECG inputs alone. And just for the non-clinicians in the audience, this is actually not something that clinicians can typically do by simply looking at the ECG. And then to the second goal that I emphasized, our platform then enables highlighting of certain segments of the 12-lead ECG that led to this given prediction in the gradient boosted model. And so this was the benefit of choosing a GBM to achieve this. This has since been validated, at least the disease part, by various other groups. And we were also able to perform various other tasks, such as prediction of ventricular mass, or mitral annular E prime, which is a diastolic dysfunction metric from the ECG alone, which is again beyond what most or any physician can really do with an ECG. And so I'll return now to this idea of setting a primary goal. And so our primary goal really with this analysis was the interpretability piece, identifying human identifiable predictors. Trade-offs of what essentially of our design decisions were the following: that the GBM performs less well than an end-to-end neural network for the prediction task. And this has been borne out, as we also have end-to-end neural network pipelines, and they do better in raw performance. The second trade-off, for example, is that the chain model approach means that the errors will be propagated down the pipeline. And so that the performance of the first segmentation model then becomes very important. just as a side note, really, we also did similar work with an end-to-end neural network pipeline in this paper here, and applied an explainability technique to also try to understand what segments are important. But there are trade-offs of that, which are that, at least in my view, and arguably, the explainability technique for the end-to-end neural network is less interpretable than the GBM approach. That's arguable. So at the end of the day, every approach has trade-offs, and so really clearly defining your goal and picking the right tool for the right job then is crucial. So I'll move for the last theme into the other bucket of data that I alluded to in the beginning, which is remote sensor data, and I think everyone's very familiar with this. To start with this, we did some preliminary analysis early on in 2017, 2018, whereby we had a data set of heart rates obtained longitudinally in a fairly large data set from the Apple Watch, and we explored their ability to discriminate various different cardiovascular risk diseases, and showed that indeed there is a signal with the heart rate alone, and actually in this case we use step count as well, to discriminate between folks who have each of these different diseases. And so this was a curious observation, one that we kind of sliced and diced in many different ways to sort of confirm that it looked like it was true. And after exploring that, we ultimately wanted to pursue farther this idea of whether similar data could predict prevalent diabetes, in part because, of course, it's highly prevalent, but also because in our preliminary analysis, it showed the strongest association. And so my last theme here really is consider in our era of large-scale digitized medically related data to consider leveraging complementary data sources whenever possible to answer a single question, because there are potentially many ways by which different types of data that you may have available to yourself can address a similar question. And so in this case, to further investigate this association, we used raw data from a PPG, photoplethysmography. This was a data set in collaboration with a company that makes a heart rate app that asks people to put their finger over a smartphone camera and flashlight, obtains a PPG signal, and the R to R, essentially the R to R interval here, can be used to calculate heart rate, but they also captured this raw PPG signal. PPG is familiar in medicine. It's used for heart rate as well as oxygen saturation, as well as for some other tasks as well. And so, and of course, it can be measured by smartphones and other devices. And so ultimately, we wanted to see whether this could be used, the raw waveform, to predict diabetes. Now, traditional methods to analyze this waveform derive a bunch of features, for example, amplitude, slope, intervals from the PPG waveform. Less done for diabetes, although there have been a few papers in the past, more for other conditions, again, using those features. But there is a biologic plausibility by which this vascular waveform might capture effects of diabetes. And so we wanted to take instead a data-driven agnostic approach to do this prediction. So we used a neural network in this case to analyze the raw PPG data. And since I'm running out of time, I'll go more quickly. We showed that ultimately that discrimination was possible of prevalent diabetes, and also further improved with the addition of age, gender, race, which is easily obtainable in combination with the PPG DNN score. And we did also do a little bit of explainability here as well, but explainability is quite a bit harder with an end-to-end neural network pipeline, which is what we had here. So yeah, I think that's my last thing. These are my collaborators and mentors, and thank you very much.
Sorry, my dog's probably screaming in the background. Thanks, Geoff. That was really interesting. Okay, so I guess we're gonna open it up to questions. There's actually a lot of questions in the chat. Okay, Courtney, should we just start with the early questions?
Yeah, that sounds great. And Geoff, I think if you stop share screen, maybe I can spotlight all of you one more time so everyone can see while you answer. I think in summary, maybe we'll do a quick clarification questions, Jean, about some of the talks, one for each. And then I think there's some broader some broader questions that I know you have across the panelists. So for Thu, the main kinds of questions were really about, I think, the data itself, the Twitter data itself, and the pros and cons of using it, whether or not it's longitudinal, those kinds of things. Maybe you can just spend 1 minute talking about your selection of Twitter data and how the pros and cons.
Yes. So when we started collecting Twitter data, and it's still currently true, there's an API for it. So you can collect anybody. It's free and open to the public to collect a random 1% sample of tweets. And tweets, Twitter is kind of different from other social media platforms in that like most of users, like over 90% of Twitter users make their profile public. So the random sample is like, because 90% make it public, then what you collect is sort of, it's like more representative of the Twitter users in general because they're mostly public tweets. However, Twitter users, I think a quarter of US adults are Twitter users. And so Twitter use is not among every US person. So the findings that I have are just to Twitter users. And so about a quarter of the population, the adults, use Twitter. But it is a random sample, and Twitter has evolved. And so like the version I was using, API version 1, it doesn't allow you to connect tweets together. So in a conversation, so just you download the tweets, but then you can't like piece together the conversation, which has meaningful like research questions. But API version 2, there is a conversation like variable, and so it's potentially possible, and that was just rolled out several months ago. And so with new features, there's the possibility of connecting tweets and kind of doing longitudinal patterns. For some of the early analyses, I also weighted by followers. So tweets that are expressed with lots of followers might be more seen than tweets that just have a few followers. So I did weight to see like in this, but I saw that the weighting of the tweets to construct error level censorship measures, it didn't change too much whether it was weighted or unweighted by the number of followers. But I think that's an appropriate question and good question to kind of always have, like who is seeing your tweets, how is it impacting the public. And then there's other, of course, platforms like Facebook. But Facebook, most people make their data private, and there's no API for it. So for research, it's more difficult to collect massive amounts of data on Facebook. So which was one of the reasons why I chose Twitter for my research.
Great. Do you know, you can take it back now.
Yeah, now that my dog's not screaming, I can actually ask questions. John, there were a couple of questions. Maybe the one that's a bit more specific to you was, how do you find the most relevant clinical applications for your methods? Do you have clinical partners from the outset?
Yeah, so and the answer is yes, but this was an idea where the method came before the applications. I mean, it's very general purpose for image analysis. If you are in any situation where you want to remove noise, potentially accentuate certain features, then it's applicable. So I would say that in the grant that I had that's coming to an end, was the clinical applications were really examples more than the applications didn't drive the methods. The methods were clearly useful for those applications. So yeah, that's how, working with people that I know and know their data.
Thanks. Okay, and then one question for Geoff. I think Alexis had a question of, when you're doing validation in independent data sets, is it still true that deep neural networks are better than GBM? I also had kind of a similar-ish question, which is, did you try using deep learning models on your kind of more clinically interpretable features and then apply like variable importance measures on top of that that were a bit more model agnostic? I think GBM has tree-based feature importance methods, but there might also be kind of just general feature importance methods for neural networks.
Like SHAP or something? Is that what you're?
Yeah.
No, so we didn't, to your question, we didn't try the latter. We didn't take the 725 vector and run that through a neural network. So we could. So yeah, that'd be sort of an interesting thing to look at. And then to Alexis's question, I mean, I think my comment was mostly a general statement, but I guess there are situations in which possibly in certain data sets the GBM may validate to do better, but by and large, for most applications that sort of I've examined it in, if properly trained, the neural network will tend to do better. So was there?
What
Yeah.
sample sizes were you using? I think I missed it in your talk.
Oh, so let's see, for the PPG work, we had 6 million PPGs, and then for the ECG work, it varies by disease, of course. I think it's on the order of thousands of patients, and then on the order of multiple thousands to 10,000 ECGs, something like that.
Okay, got it. Okay, so I guess there was one question that was to the general, to all the panelists, which is kind of like, I guess the question was what types of software you guys like to use for doing your analyses, and maybe more generally speaking, what types of computational resources do you guys rely on? We could just go in the original speaker order.
Okay. I think there's like a few different steps for the project to occur. And so my project has like multiple components. So I rely on multiple different people with different skill sets. So there's like computer scientists, there's social scientists, social people, epidemiologists. So then one of the first steps is to collect the Twitter data. And so we currently have it continuously collected and saved on a server. So then I think that took several months to kind of write the code and kind of build like a process to continuously collect tweets. And then we're currently now trying to do the academic track API, which has more features. And so setting up a new server data collection. And once that's done, there's machine learning models to develop the sentiment analysis model. That's done. And now we're building models to label racial prejudice. And of course, that's more complicated than labeling the sentiment of tweets. And so we've been tackling that for a few months, like I guess almost a year. So that's a new thing that we're working on. And then once the machine learning models are created, then the tweets are labeled and then they become available in a regular epi analysis. And so then the epidemiologists take over and analyze the quantitative data. We also analyze the tweets qualitatively. So multiple different kind of steps along the way by a team.
Yeah, so for me, our work's been, for this project, worked in Python, but I'm always back and forth between whether I want to use Python or whether I want to use R, typically to do these projects. And up and coming is also Julia, which is kind of sits in between a low-level language like C and where R and Python are. So it's particularly powerful. Didn't really need that for this project because we took advantage of the independence to reduce our computational costs. And I think Alexis's question was just Jen's question was a little bit more general, asking about where you might, if you just want to do general Bayesian analysis, well then I think you're pretty free to put, R has a lot. You have to look at specific packages. Stata now has quite a bit for routine kinds of analyses, certainly in SAS does too. And I'm sure there are libraries in Python to do this. So if you have a favorite thing to start with, then I would work with that. The limitation being with SAS and Stata, if your modeling starts to go outside of the box in any way as to what is a standard approach, then you're going to be stuck and you're going to have to move out. Whereas with R and Python, you can potentially build on what you're doing.
Just quick follow-up, John. Are you using a specific Python package for your Bayesian analyses, or are you doing it completely from scratch?
Doing it from scratch. I mean, we use numerical Python packages.
Yeah.
But,
Okay, it isn't a Bayesian Python package.
No, we're doing that directly.
Nice.
But there is sort of, if you need to do Markov chain Monte Carlo to do your optimization, there's Stan is, I think, now becoming the go-to package to do that. And actually, for a lot of standard and quite flexible Bayesian modeling, I would really recommend looking at R-INLA, which is a non-MCMC approach. It's incredibly powerful. Probably, all of your standard statistical models and much more, including spatial stuff, is in there, and you can really go a long way with that. And it's also fast.
Yeah, so we also use primarily Python for almost everything, but I guess this discussion is great and made me think about, I guess, whatever my first theme, which was right tool for the right job. So certainly there are situations that we've been in where it just makes more sense or is easier to do certain analyses in Stata or R, and so we'll take a data frame from Python and move it over and complete this or that analysis in the other program. So yeah, right tool for the right job across the board.
Nice. Yeah, that makes a lot of sense. I also jump a lot between the languages. Okay, there was one question which I think was originally directed at Geoff, which was what kinds of quality filters did you have to apply to your ECG data library, and do those filters limit the translation to clinical practice? And I guess maybe more generally for all the panelists, you guys are all dealing with data that could potentially be messy due to various artifacts. Like one example, when I was thinking of what Thu was talking about, you're using a machine learning model to label sentiment, but the machine learning model could be wrong as well. And how does that kind of measurement error affect things? So maybe the speakers can kind of talk about this.
Yes, I think there are limitations, and then so I think when a lot of the papers that I do, they're like both the mixed methods. So I do the qualitative analysis with the quantitative. Sometimes we can kind of see the limitations. So then for the sentiment analysis model, it labels the emotional tonal tweets. But then our most recent paper is working on the Atlanta spa shooting. So the killings of majority Asian women. And so we saw like a spike, and this was the first time that we used a hate speech detection model. And so there was ambiguous findings, like why are we seeing kind of a spike in negative sentiment tweets, but also a spike in solidarity speech. And so the qualitative analysis helped us to pick apart some of the themes and the intersections. And so I think the qualitative analysis with the quantitative can help kind of provide the limitations of the machine learning model, and kind of help build like the next direction. Because I took the sentiment analysis model was the first we built because it's the most simple, but then now we're seeing more complexities and trying to build like more complicated models that can label kind of more nuanced things. And one of the things we see in, I guess like I did the comment, like one of the things about racism is that there is like, sometimes the tweet is negative, but that doesn't mean it's negative. It could be like, racism is bad. And like, so then like there's a whole bunch of complexities with like trying to quantify social constructs and quantify that.
Yeah, so to the ECG question, there's actually, we didn't apply anything discrete to filter the data per se. But if I think Arctic asked the question, if you're interested to know more in detail, there's a whole volume of wisdom we've accumulated over years now about ECGs, and basically there's a lot of variation by manufacturer and filters that are applied that actually applied heterogeneously to the raw data, and so then there's methods to back engineer that. So that, if you're interested in very detailed specifics, happy to chat offline more, but there is some degree of normalization that occurs, at acquisition that somewhat precludes the need to do it, beyond what's been done already by the manufacturer. But that starts to break down if you look across different institutions. So that becomes a problem, transferring things between institutions potentially. Happy to talk more offline.
John, I don't know if it's relevant. This question is relevant to you. I think you were talking specifically about denoising data to begin with. So you were dealing with messy data. Okay, maybe just to wrap up, and maybe this question is motivated because I myself am a statistician and a machine learning researcher. I guess I'm curious what kind of are important but unaddressed challenges that you think machine learning researchers can really help out? Like, what tools do you wish people like us could be building for you guys? And John, I guess you have the technical viewpoint as well already. So.
I guess one question that has been tossed around a little bit, but I would, underline is, what kinds of machine learning, how can machine learning based tools be applied if it's causal analysis, or can they, or are there, innovations that can be made down that line?
Yeah, definitely a super popular topic. And definitely still an open research area. All right.
I guess there's like so many possibilities, right? There's like so much to know, and there's so much to know, and so there's like all these possible research questions. And I think like one of the richness is like collaboration, because I think so computer scientists and machine learning people are, I think, really interested in social problems as well, and kind of like forming teams and kind of translating like the knowledge that is like within different disciplines together to make more powerful and robust research. I think it's one of the rewards of this area.
Yeah, that's definitely true. Just more collaborations would be helpful to all the fields.
I think that's another area where, we're still early on, is moving from just predictions to making decisions, and potentially cascading decisions, and having machines learn like optimal courses of action.
I think we're at time. This has been really, really great. From my view, I just wanted to thank all of the speakers for giving a very wide range of applications and use cases for computational methods. And so I hope people can reach out if they have further questions, and please do fill out this survey in the chat if you have not already for us, and have a great day. We'll see you at the next seminar in 2022.
Okay. Thanks, everyone.
Thanks.
Thank you.
Thanks.